Assalamualaikum. Hi. My name is Muhammad Saifullah bin Nasir. Okay, my ID number is 2022 490 366. Okay, 2022 490 3666. So today I would like to present regarding the radiographic image evaluation for lateral elbow. First of all, we go to the radiographic anatomy. So for the radiographic anatomy, in the lateral elbow, it should include the 1/3 of humerus, and then we also include 1/3 of radius ulna, and then at the elbow side, at the elbow joint, the medial trochlea in superimposition, and also the epicondyle also is superimposition. And then we continue to the criteria image. So for the image evaluation, we use the Passman method. So we start with the P. P is standing for projection and positioning. So from the image that we see, this is a radiograph of lateral elbow. So why I say this is because 1/3 of the humerus are demonstrated with the elbow joint, and also with the 1/3 of the radius ulna. And then from the radiograph, we also can see the both of the epicondyle are in superimposition each other. So from the radiograph, the position of this radiograph is incorrect. So it's not in true lateral positioning. So this is because the radial head is not superimposed with the coronoid process. And then we also can see the radial head positioning is anterior on the coronoid process. And from the radiograph, we also can see the radial tuberosity is not demonstrated clearly. So how to improve this projection? First of all, avoid position proximal of distal of humerus too depressed. Okay, and make sure the distal radius ulna and the humerus are the same level with the IR. Make sure the table are the same height until the top of shoulder, and the humerus and the elbow joint and the forearm in the same level. And then make sure support the distal forearm with the immobilizer to prevent the distal of radius ulna is depressed in a depressed positioning. So we continue with the A. A is for alignment. So the alignment, the alignment in this criteria, we have 3 alignment. The first is a patient with beam, and then beam with IR, and IR with patient. So we have 3 alignment. So the alignment is regarding the demonstrating of the collimation. So from this radiograph, the alignment between X-ray tube and cassette cannot be determined because there's no evidence of for collimation. Also, the alignment between X-ray tube and patient cannot be determined because there's no evidence of for collimation. But the alignment between patient and cassette is incorrect. Okay, this is because the length of axis humerus is not equidistant to the lateral border of the film. Then we can see from when we cross the IR, the center of IR is not direct to the center of elbow joint. So from the radiograph, we can determine the centering point. So the centering point of this radiograph is at the area of the fat pad of the elbow joint. But for the standard centering point for this lateral radiograph, it should be at the direct to the mid elbow joint, or a point approximately 4 cm medial to easily palpate posterior of olecranon process. So we continue to the C. C is for collimation, and always you can include regarding radiation protection. So collimation should be done to all 4 borders of the film, and should include, the first one is at the superior border. The structure that should be included is 1/3 of humerus. So the upper part, we must include the humerus, And at the both lateral border of the collimation, that should be include the skin margin of the humerus and 1/3 of the radius ulna. And at the inferior border of the collimation, the structures that should be include are the skin margin of radius ulna, the ulnar bone, and the olecranon process. And make sure the collimation is not too big or too small until the collimation can cut the region of interest. And then for the radiograph, there is no evidence of radiation protection is demonstrated. So we go to the E is for its exposure. Okay, from the radiograph, the KVP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of the thin structure, which is the humerus and radius ulna, can be seen, and the bony cortical outline of the thick structure, which is the lateral and the medial epicondyle, also can be seen. How about MAS? The MAS used is adequate for detail and density. This is because the bony trabecular pattern of the thin structure, which is the humerus and radius ulna, can be seen clearly in the radiograph. And the bony trabecular marking of the thick structure also, which is the lateral and medial epicondyle that superimposition in each other, also can be seen. And then for the radiograph, there's no need any changes of exposure for this radiograph. So we continue with the M. It stands for marker. There is evidence of an anatomical marker shown in the radiograph, correctly placed on the left side of the body and placed appropriately, not superimposed at any region of interest. And then A is for aesthetic value. So the film size used is 24 by 30 centimeter, which is sufficient to demonstrate all structure of the interest. And then there is no evidence of artifact on the radiograph. So name, for the last is name, the patient name and ID or IC or the RN, date of examination, place of examination are clearly visualized on the radiograph at the appropriate area, and no superimposition with the structure of interest. Okay, so from the evaluation regarding the radiograph, this image are acceptable because there's no cut at the region of interest, and the image quality in a good quality. So that's all for my image evaluation. So thank you and goodbye. Assalamualaikum.